So what about the risks and the complications? I know it's not a pleasant topic, but it's a very important one. Remember, an ounce of prevention is worth a pound of cure. That's why you select me. Safety first. Now, if for some reason you're not a candidate for LASIK, then I'll direct you towards another procedure such as advanced surface ablation, the phakic intraocular lens, the refractive lens exchange, or INTAX perhaps, or we simply won't do surgery. Safety first. Well, what about the need for glasses after your laser surgery? It's very rare, very rare. The vast majority of people never need distance glasses following LASIK. But a few do, and I don't know who will and who won't. So everyone must plan for the potential to need glasses, especially for night driving and especially if you have monovision following your laser procedure. Now, a certain percentage of patients experience glare, halos around point sources of light, or starburst coming off oncoming headlights or overhead lights, or a decrease in what we call contrast appreciation, that is, to discern subtle shades of gray. Actually, everyone will experience all of these side effects for the first 4 to 6 months, sometimes a year. But in, again, the vast majority of patients, the symptoms of glare and halos and starburst and decreased contrast sensitivity goes away. But in a few patients, very rarely, these will remain. Now, for the patients where these symptoms remain, for the most part, they're a mild annoyance. They're not profoundly disturbing. But a few patients are devastated by the presence of severe glare, halos around point sources of light, or starburst coming off of point sources of light, or significant decrease in contrast such that they can't drive at night or function well in a dimly lit environment, such as a conference room or a classroom where you need to look at a blackboard or a screen in a dark room. Again, this is very rare, and I'm happy to say in my practice I actually don't have any patients that are devastated by disturbing glare and halos, and partly it's because we're conservative in who we select for laser vision surgery to begin with. Now, as I said earlier in the wavefront guided section, there's no question that wavefront guided LASIK diminishes the induction of these aberrations that cause glare and halos and starburst. But it doesn't eliminate it completely, and there is still a small risk of being debilitated by these disturbing visual symptoms. Now, sometimes, actually about 10% of the time, you'll either be undercorrected, that is, we don't get all of the nearsightedness or farsightedness that we intended to, or you'll be overcorrected, that is, we get more of the nearsightedness or farsightedness than we intended to, or you will have the induction of astigmatism where no astigmatism existed before. Now, if these are very mild, you won't be bothered by them. But if they are significant, then you will need to wear temporary glasses for the first few months until we can do an enhancement. Now, as you can imagine, enhancements, my overall rate of enhancements is about 10%, but enhancements are more commonly needed in the very nearsighted, the very farsighted, and those that have an initial amount of astigmatism which is quite high. Typically, we do the enhancement about 3 to 4 months following your initial surgery. We go back to the laser center, we lift the existing flap, we apply the laser for a few, 10 to 20 seconds, lay the flap back down. Again, you go home, you keep your eyes closed that night, you examine the next day, and generally a second enhancement is not required. Sometimes it is, a very small percentage of cases, a second enhancement is required, but generally after the first enhancement, we achieve our visual goals. So let's discuss the dry eye. Now, the dry eye is more common in perimenopausal women, especially farsighted perimenopausal women. Now, LASIK in and of itself can induce a dry eye, and it can certainly exacerbate an underlying dry eye. So what we do is we are very diligent in checking at your preoperative examination for the presence of a dry eye. And sometimes quite disappointingly, we have to postpone the surgery, sometimes for months, sometimes up to 6 or 8 months, if there is a significant underlying dry eye. So if we have to cancel an already scheduled surgery because of the dry eye, I know it's disappointing and I'm sorry, but remember, safety first. You'd never want to walk into an airplane and sit down and have the captain come on the loudspeaker and say, "I'm sorry, we're having mechanical difficulties," and you yell out, "Oh, take off anyway." If we can't do your surgery because it's not safe, we'll do everything that we can to make sure that it is safe, and then we'll proceed. So the treatment of the dry eye before your LASIK will consist of the diligent and frequent application of non-preserved artificial tears, as well as oral dietary supplements like flaxseed oil or fish oil, and also we'll plug the tear drains to help preserve what tears you put in your eye and the little bit of natural tears that your eye makes. And we may have you use a topical anti-inflammatory drop called Restasis, and even possibly have you use an oral antibiotic for a couple of months, which is a tetracycline derivative called doxycycline. Together, you and I as a team will get your dry eye better before we proceed with LASIK. But even if we get a perfectly non-dry surface, a small percentage of patients will have post-operative dry eye. Or conversely, let's say you start off with no dry eye at all, and then we do your LASIK, a small percentage of patients will end up with a bothersome dry eye. Now, the dry eye after LASIK is quite a nuisance in that your vision isn't as good as it could be, your eye's not as comfortable as it could be, and it's harder to treat the dry eye after LASIK than it is before LASIK. Again, using the same treatment regimen, but it can take a few years to resolve after LASIK. That's why we do everything we can before LASIK to make sure that we don't proceed until the eye isn't dry. Let's review flap problems. We briefly touched on this earlier when we were examining the differences between the conventional microkeratome and the interlace. Let's talk about some of the complications in greater detail. Now, flap problems can occur either during the procedure, called intraoperative problems, or after the procedure, even many years after the procedure. During the procedure, the flap can either be cut too thin, or when you cut the flap, it can have little buttonholes in it, almost like Swiss cheese, because the microkeratome comes up and skirts over the surface and then goes down, and when you lift the flap, there's a little hole in it. That is a significant complication. In those instances, we lay the flap back down, position it perfectly, and then place a soft contact lens on the eye for a few days and let the eye heal. Then we wait usually 4 to 6 months for that flap, either the very thin flap or the buttonhole flap, to become secure. We go back to the center, create a new, slightly deeper flap, and perform the laser procedure. Now, that has happened to me about 10 times in 40,000 flaps. And I'm happy to say that each time we've gone back within the first 6 months, recut a flap, perform the laser, and all of those patients are seeing about 20/20. Now, what about disasters with the flap? Those are very rare, and I'm happy to say I have had no cases of flap disasters, but they can occur. One type of a flap disaster is if the microkeratome shreds the flap completely, or if it tears the flap off and the flap is lost for some reason, we can't find it. In that case, the patient is obligated to wear a contact lens, generally a rigid gas permeable hard contact lens, forever to achieve their best vision, or may have to undergo a corneal transplant operation to restore the natural curvature of the cornea using a donor cornea. Now, what about post-operative flap problems? Those generally occur within the first 24 to 48 hours, or they can be very late and can occur many years after surgery as a result of physical trauma to the eye. Now, the early flap problems generally consist of slipping of the flap. If the flap slips within the first 24 hours or so, we go back to the laser center, we reposition the flap, we place a contact lens on the eye for a few days. Those eyes do great. In my experience, this has happened about a dozen times in 40,000 cases for me. After repositioning the flap, after a week or two, the vision is just as good as the other eye. In fact, I've had one case where both flaps slipped. And in that case, again, I repositioned both flaps, and within a few weeks, the patient was seeing 20/20 and doing fine without any evidence of problems. Now, very rarely, and I've seen this only once in the last 10 years of LASIK, and actually it wasn't even my patient, was someone that was working on an electrical project and a wire sprung back and hit him in the eye and actually tore the flap off completely. And it was lost, it was gone. And so what we're doing in this case, he does not want to have a corneal transplant. He sees fine with a contact lens. He's just wearing a contact lens in that eye and he's doing fine. But again, like I said before, with flap loss, would be possible that you would need a corneal transplant operation if you traumatically lost your flap months or years following your laser procedure. Now, in a very small percentage of overall cases, but a not so small percentage of patients who are highly nearsighted, that would be, say, -6 or above, we can get these little fine microfolds. They're almost like stria, or those fine folds that you notice when you tear cellophane off the roll right before you cut it on that serrated edge. It creates those fine little folds. That can be seen in about 5% of the high myopes, that is, the highly nearsighted patients, -6 and above. Now, there are many times when patients have fine microfolds and there's no effect on vision or visual quality. But in a certain percentage of patients, you can have permanent decrease in vision and an increase in the possibility of glare, halo, decreased contrast sensitivity, and also starburst around lights. Now, if you have microfolds, and we notice them early on, and we generally notice them early on, in certain cases, we can go back to the operating room, lift the flap, and attempt to iron out those folds. But there is no perfect treatment for microfolds, and in most cases, the microfolds don't get that much better, and patients are left with much improved vision than prior to surgery, but not vision that is up to their goal. And in those cases, patients will generally need to wear glasses, not all the time, but particularly for night driving, which can help, but not make it perfect. Or if the vision is just not what they expect, particularly even with glasses, then they may be obligated to wear soft and even sometimes hard contact lenses. In the many thousands of high myopes, over 6 that I've done, I do have a number, I don't know the exact number, I do have a number of cases with microfolds. And I have to say, I don't have anybody where the microfolds are severe enough where they're wearing glasses full time or wearing a contact lens full time, but it's possible. So you need to know about it, particularly if you're a high myope.